Hi everyone, I couldn't be with you today because I've got COVID, so I'm going to go through the main points of this tutorial with you. So we have this patient, Mr. Lee. Mr. Lee was found on the floor at home by his daughter in the morning. He was well the night before, but he got up in the night with a headache. When he tried to stand up, he fell down and couldn't get up. He's now come into hospital with the ambulance, and the ambulance officers noted that the left side of the father's mouth is drooping and is not using his left arm and leg. So the first thing is, let's think about the problem representation for the patient. So problem representations always have the epidemiology. So he's an 80-year-old man. Yeah. Time course with acute onset, probably several hours in duration, of left-sided hemiparesis and ipsilateral face weakness. Notice that I've used the medical terms in order to focus our attention on a more medical description of the problem, which helps us with the differential diagnosis. Okay, so in the ED, what further specific history should be sought? So we pretty much know that he's had a stroke. So we need to do the history that might allow us to assess the severity of the stroke. And there is a scoring system for that. And also we need to take a history in order to find out the cause of the stroke. So we'd want to know a cardiovascular history in particular, and also a CNS history. Has he had this before? Has he had TIAs before? That kind of thing. The stroke assessment can be found on MD Calc. Okay, so in a physical examination, similarly, we want to do a full neuro exam as well as a full cardiac exam, and then we'd want to do some other systems. But mainly we want to be looking for things like atrial fibrillation, murmurs, good causes of emboli, bruits in the carotids, signs of atherosclerosis or other vascular disease elsewhere, signs of previous of weakness. Does he have any deficits anywhere else? Okay, so he's not seeing things in his left visual field, and he also has left-sided unawareness. He has decreased reflexes on the left side, though no spasticity, and an upgoing plantar reflex. We notice he's hypertensive. Now, this can be misleading because hypertension can occur in reaction to brain swelling. And so you would need to look at the history to find out whether he was truly hypertensive. We notice that his pulse is 80 and irregular, so we'd want to do an ECG because he could well have atrial fibrillation. This could be the source of his stroke. What is the likely arterial territory and the region of the brain involved? All right, so left-sided weakness means the right side of the brain is going to be involved, and it's going to be in the anterior circulation, the MCA, sorry, middle cerebral artery or anterior cerebral artery, but definitely the middle cerebral artery, in order to give the wide range of symptoms present. It's on the visual problems could well be due to involvement of the optic radiation as it passes through the behind the eye, so that can still be affected in anterior strokes. Often people have a misconception that maybe just posterior strokes can affect the vision, but no, that's not true. So we know that he's got an anterior arterial territory stroke. Okay. What are the pathological processes that have led to Mr. Lee's stroke? All right, so given the history of atrial fibrillation, embolus has got to be right on the top. And the embolus could be straight from the AF, or it could be an embolus from a cholesterol plaque that he didn't have any bruits, but that is still possible. The second will be thrombosis. So he could have atherosclerosis, and in that case, a thrombus forms at the area of atherosclerosis, just like in the coronary arteries, usually due to ulceration. Other less common things, arteritis can happen, and that can block off arteries, but that would be fairly uncommon. He might have had an intracranial hemorrhage. due to an aneurysm rupturing. Again, a possibility. Okay, so I would say that the most likely thing was embolus followed by thrombus. Okay, so what radiological investigations might be useful? The easiest and fastest thing to get in the hospital ED department is a CT for stroke. They will interrupt their CT schedules just to get that stroke thing done, because they know that if they find something they can intervene with, then it will save the brain. MRI gives a really detailed view of the brain, but often hard to get into. So go for CT. What other radiology might be quite useful? Perhaps an echo of the heart. Yeah, maybe, but definitely go for that CT. What are the appropriate blood tests to order? Okay, so remember, there's a tendency to underorder blood tests. We need a full blood count. We need renal and liver function tests if he's going to have a CT. We would need clotting factors. What other things would we want to do? Probably CRP, just to check out that vasculitis. And then I've run out of ideas. Let's have a look and see what they say. What have we written here? Yeah, here's a few more. I always underorder as well. Cardiac enzymes. Yeah, and the rest we did pretty well with. Okay. What one other investigation is needed to find a common stroke etiology? Probably, I've mentioned an ECG and an echo. Yeah, okay. So that's pretty good. So we've got him well investigated now. He's had his echo, he's had his CT, and a raft of blood tests, which probably indicate where his stroke is likely to have come from. What does it show? His CT. It shows that on this side of the brain, the swelling, because the normal markings here, normal markings have been obliterated, and it all just looks kind of fuzzy. So they're intact kind of posteriorly, but all the way through here, we've got loss of definition. All right, so what's happening in his brain tissue? So we're going to think about the natural history of stroke. And the first thing that happens with stroke is edema. So the blood vessels are also involved in the stroke. They become leaky and they leak out fluid. And it's only after about 24 hours that we see the first cellular changes. So this will all be due to edema. Right, here's his ECG. We can see that it's irregular with lack of P waves here. So yes, he's probably got AF. Okay. So he's not eligible for thrombolysis because at the time of his stroke and reaching hospital. So thrombolysis dissolves the blood clots, and any cells, any bits of brain that were kind of gray, not dead, but just hanging on, the thrombolysis can save them. It's called the penumbra area. And so people who are taken to hospital immediately after stroke, you can save their bits of brain by immediately thrombolizing them. However, he's been there a long time, so thrombolysis will not help him, and it does come with risks. And the risk of thrombolysis is that he will get a bleed into his stroke. So if it was an embolic or thrombolic stroke and we removed the thrombus or embolus by dissolving it, then there's a possibility he might get a bleed. So that is increased from 1.3% to 6.8%. Yeah. So TPA is the thing that we use, tissue plasminogen activator, to get rid of the thrombus, and it increases the amount of people who have good outcomes after stroke. Excuse me. And they've explained this in terms of the pathology of the ischemic stroke. Okay, there we go. That was a very short run through the tutorial. Bye.